welcome back to another video. Today we're going to be talking about patient involvement in their non-surgical periodontal therapy. And essentially we want our patients to be co-therapists. If you've heard me talk about motivational interviewing at all, you know how passionate I am about really getting the patient to come along on this periodontal journey with us because it is essential for patient compliance and it's essential for remission of the disease. But why is it so important? Essentially, the primary etiology of most plaque-induced gingival diseases and periodontal diseases are caused by that plaque, biofilm. And what we know about biofilm is that over time, it becomes more and more pathogenic if it's not disrupted. That's the nature of biofilm. It gets more pathogenic as time goes on because it attracts more pathogenic bacteria and it creates these defense mechanisms in order to protect itself. So the more often that we can disrupt the biofilm, the less pathogenic it's going to be and the less amount of inflammation the patient is going to have. So it is essential for the patients to really be on board with this. And so today we are going to talk about different aids that patients can use, which aids are appropriate for which specific areas, and how we can talk to the patients about how they use these. We know that obviously toothbrushing and floss has been pushed to the general public, that it is essential to do that in order to keep the mouth healthy. But over time, as periodontal diseases cause damage, specifically periodontitis, we start to lose attachment and we start to lose that interdental papilla. As that decreases, we are left with some pretty unique anatomical features of the mouth that make it a lot trickier. There are many of our perio patients that regular brushing and flossing won't do very much because they have attachment loss and they have anatomical features that are different than just a normal, healthy patient that has a stable periodontium. So let's look at that. Let's look at why. And the main reason is our embouchure spaces. Embouchure spaces are the spaces in between our teeth where our interdental papilla is supposed to be. We can call these different variations of embouchure spaces 1, 2, and 3. You can see them on the pictures here. These pictures are from the Gehrig textbook. It is referenced below. As you can see, the first embouchure type 1 is a very healthy mouth, right? That interdental papilla completely fills the interproximal space. It is knife-like, it is firm, it is not bulbous, and it is normal. This is an example of when toothbrushing and flossing are just going to be just fine. It's going to be able to clean in that area, and the interdental papilla sort of protects the other areas, right? It's covering everything up. Embouchure 2s and 3s are a little bit different. Here in the pictures, you can see an embouchure 2 space. As you notice, the height of the interdental papilla is reduced. You can really see that there is some interproximal loss there, so the interdental papilla doesn't fill the full space, but it fills part of it. For these areas, we may not have some of that root exposure quite yet, but we may have CEJ present. This means that some alternative aids, which we're going to get into the nitty-gritty of these in just a second, but things like tufted floss, toothpicks, wooden wedges, interproximal brushes can really make a difference when it comes to trying to get into this space a little bit better. Finally, on the way right of your screen, you're going to see an embouchure 3 type space. As you can see in the picture, the interdental papilla is completely missing. It has completely reduced. This has a lot of cal, and there is no interdental papilla in that interproximal space. And again, the aids that we're going to recommend for this patient are quite different. We need things that can fill that space, right? Interdental brushes are great for this. And we'll look at a couple pictures to see why in just a second. What you don't see here in these pictures is another type, and it's not really an embouchure space thing, but we can have bulbous tissue, right? And that means that it's just like an embouchure space type 1, except for the interdental papilla is swollen and completely fills or overfills that space. So it's causing this really, really tight area. Floss is probably going to be your best bet. We don't want to put something bigger in that space because it is a smaller space. As our embouchure spaces get bigger, we now have a lot of root exposure. that causes a problem because a review from Dental Anatomy, a lot of our teeth have root concavities or root depressions on either the mesial or the distal. So this is important to remember. It's important to remember which teeth have these concavities, because if a patient has loss on one of these teeth, we have to remember that and recommend things that can actually clean it. These pictures show exactly why floss is not indicated for these deeper areas. Floss, when we learn it and when we teach patients about how to use it, we want to focus on the C shape. That's because that's how it adapts to the tooth. But it's a physical impossibility for the floss to actually reach into the root concavities or the root depressions in order to remove the plaque from those really tight corners and pockets of the teeth. So let's talk about all of the different aids that we can recommend. And we'll start with floss. Floss is the OG, right? We hear about floss. We, in dental hygiene school, learn that we teach patients about floss. It's like one of the first things we learn how to do on each other. They give us some floss and say, here you go, floss each other, just to get us used to being in the mouth. And so floss is really, really great. Like I said, it cleans embouchure 1 spaces, and it's really the only thing that can clean that really tight area. But what we do know is that floss doesn't do a whole lot of good in the statistics in the literature. It may reduce bleeding, but honestly, patients probably say they do it a little bit more than they do. And there's really not a whole lot of evidence that it really actually reduces caries rates or reduces gingival inflammation. So the Dr. Oz episode, I think, came out that said really flossing doesn't do anything. And he wasn't really wrong. It's just the way that he presented it wasn't quite as scientific as we would like. What the science actually says is there's a lot of different aids that are way better than floss because most people have some sort of loss. So recommending floss for a patient that has embouchure 2 or 3 spaces, yeah, it's not going to do anything. So he was right that the literature doesn't support it, but that's because other interproximal aids are way better. That said, floss is very common. Everybody knows about it. It's cheap and it's available. Next, let's look at tufted floss. Tufted floss is a little bit different, and a lot of patients who've had braces probably have already experienced tufted floss. Tufted floss is just like regular floss, but it has this kind of spongy material in the middle. So it has kind of like a floss threader hard end, and then it's spongy in the middle, and then it has another floss threader end. Again, very commonly recommended for orthodontics. Also really good for bridges, type 2 embouchure spaces, or teeth that are really spaced out, diastemas. And it's just a really good alternative to floss because it does have that puffiness, and so it covers more space. The good thing about this is that you use it very similar to regular floss. It just has more capabilities because of those hard ends. You can use it just like a floss threader. An interdental brush is one of my favorite. An interdental brush is actually a really small brush, as you can see in the pictures. And I should just say, I got all of these pictures from Amazon. I do not endorse nor am sponsored by any products, but these are the most commonly recognized. That's the only reason that I included these specific pictures. That said, there's many on the market and they're all very, very good. I chose the picture on the right because TP does a good job at showing the size charts. A lot of the times they'll offer a case with different sizes for offices, so that way patients can kind of try out different sizes. But this tool is amazing, and most patients really, really enjoy it and are compliant with it. It's important to note that this tool does way better at type 2 and type 3 embouchure spaces because of the root anatomy. As we saw previously, through the cross sections of the teeth, again, this has the bristles and it's able to get into those root concavities way better than floss. We teach patients how to use the C shape of floss, and that doesn't work when you have a root concavity. So an interdental brush is great because it has the bristles, it's more 3D in nature, and it covers a lot more area. They put it in between their tooth and use it just like floss or a toothbrush and just move it back and forth. Interdental brushes are amazingly effective. They're better than toothbrushing alone. They're better than regular floss. and they help to reduce inflammation. Next, we're going to talk about the end tuft brush. The end tuft brush seems like a kind of an underdog contender here, but patients love the end tuft brush. The end tuft brush is just essentially a toothbrush with a tiny, tiny little end. And I've had so many patients really enjoy this. Because of the small size of the tufts at the end, it can get into a lot of places. Think like the terminal molars, the distal of your terminal molars. Those are really tricky. Same thing, it's good around orthodontics. It's good around the brackets. It's also really, really good for those buccal and lingual furcas. Those really we cannot get with floss because they're buccal and lingual. Same thing with the interdental brush. We don't use those on the buccals or the linguals. The end tuft brush is really, really great at getting into those furca areas on the buccal and lingual surfaces. They're also small enough, probably depending on the patient, obviously, but small enough to really get in those type 3 embouchure spaces where you don't have any papilla. It can really get in there because it's really small and easy to adapt. You're going to use this exactly like you use a regular toothbrush, nice circular strokes and gentle. Next, we'll talk about toothpicks. Toothpicks, again, are a little bit of an underdog, and I'll just say, I have had so many patients that are toothpick loyalists. They say, I got a toothpick on me all the time. And I think we kind of give toothpicks a bad rap, but if you use them appropriately, correctly, softened with water or saliva, they're actually really soft and adaptable, and they're, easily disposable. They're easily accessible. You can get them in every restaurant you go to, right? What makes it easier for a patient though is when you include a handle. So a toothpick with a handle, again, this came off of an Amazon product, so they are available, and you put the end of the toothpick in the handle and you use it very similar to an end tuft brush in adaptation. This can reduce bleeding and inflammation just as well as floss can, and the technique is very simple. You just soften the end with either your saliva or some water. I know some offices recommend soaking it in like a chlorhexidine or a mouth rinse. You could do that. Some offices soak it in like hydrogen peroxide, but this also, just like the end tuft brush, can be used in the buccal and lingual furca regions, and it can be used in type 2 embouchure spaces or 3 if you can obviously fit it in there. But it is good for a lot of those areas of when we have that loss present. Unlike the end tuft brush though, you want to be gentle with this. Obviously it's wood and it can splinter or cause damage if you use it too hard. 45-degree angle towards the gum, use it very gently in kind of a sweeping motion, and it removes that bacteria or disrupts the bacteria from under the gum. Next, we have a wooden wedge. These are quite a bit less common than the others, but they still exist. I still have patients that have said that they've used them. It's just not quite as common. The only one I could find on Amazon is what you see here on your screen, Stimudent. We have a couple of different ones that we have in our perio lab, but these are the ones that I could find most readily available, over the counter through Amazon. So the Stimudent is a short wooden stick, and it's shaped in a triangular wedge. So that's kind of what sets it apart than a toothpick. A lot of people are like, isn't that just essentially a toothpick? But it's really not. The triangular shape of the wood helps it sort of adapt and kind of remove, very similar to like the blade adaptation on a Gracie instrument. It has been shown to improve inflammation better than just brushing alone. It's really good for type 2 and type 3 embouchure spaces, but because it's a lot thicker than a toothpick, it doesn't soften very well, and so we really don't want to recommend it in a root concavity or an area that we would potentially damage something. Again, you moisten it and you insert it with the flat side next to the gum, and you just kind of adapt it very similar to a toothpick, less back and forth, kind of more of like an in and out motion. And then finally, we're going to talk about tongue scrapers just for a sec, not because it's interproximal, right? But because it is another way to disrupt the bacteria in your mouth. We have biofilm on our tongue as well, and that can cause some problems, especially for perio patients. They have a very unique flora in their mouth that is just a little more pathogenic than the average standard patient that doesn't struggle with perio. Typically, our tongue is coated with debris from the food we eat, plus the bacteria that's present. It can cause a couple different products. One is hydrogen sulfide, 2 is methyl mercaptan, and then 3, just in general, some volatile sulfur compounds, or VSCs. Those cause a lot of malodor, so bad breath essentially. And people have said that perio breath, perio breath, has a very unique smell. And part of the reason, not all of the reason, but part of the reason is that the periopathogens specifically really produce that methylmercaptan very abundantly. So those perio patients may struggle with some sort of malodor due to the disease. Using a tongue scraper can be hard to get used to, so we recommend for our patients to start at the front or even the middle, whatever they can handle. It does cause quite a bit of a gag reflex. So if you have patients with a gag reflex, you kind of have to build up that sensation or that tolerance to how far you're going back in the mouth with the tongue scraper. So if you start at the front, do a swipes, maybe the next day go a little farther back, the next day go a little farther back until you're all the way to the back and really reducing it from the back, because that's where most of them are. The reason they're mostly at the back is because they don't get disrupted as often. People tend to brush the front of their tongue, but not the back of their tongue. So those filiform papilla that acts like that carpet papilla, it's gonna trap all of that in. And if you're not disrupting it, same thing, it's gonna cause a lot of bacteria to flourish there. So if we can get our patients to disrupt that, that is gonna help with some halitosis and perio breath. I can't leave out the subgingival irrigator when it comes to periodontal health and self-care, but that is a whole topic on its own. And we like to keep these concept overviews just really short. So we are going to cover subgingival irrigators in a whole separate video. Stay tuned, that will be coming out very shortly, and I will see you on the next video. If you have any questions, go ahead and put them down in the comments down below, and I will be sure to address it. Thanks for listening, and I'll see you on the next one.